Welcome, and as I said, I'm Dr. Brian Dury, and this is Dr. Warren Brenner, whom many of you may know from just close by here, and we're very pleased that he took time out of his busy practice to come and help answer questions this afternoon. So just before we start, I'd like to acknowledge our sponsors who are up on the screen there. Not physically, but we do have their logos. And we would not be able to do these meetings without their strong ongoing support, which we really appreciate. So without further ado, we can start with the questions. As you know, this is kind of an open session. Tomorrow we go into more detail about each of the different topics, from diagnosis all the way through to relapse and the different new trial options that might be available. But right now, we can focus on individual questions that you have, maybe that have been on your mind for a while, where maybe you can get a couple of answers, maybe a couple of different answers up here, and we'll be glad to do our best to help you with your questions. So,
we're going to start with the man in the green shirt.
How often does the picture of the bone marrow closely monitor the spike? For instance, someone with pre-myeloma, MUGUS, or the other myeloma.
Like a smoldering
smoldering,
stage.
That's the word I'm looking for. How often
so
does
you want to comment on that, perhaps?
Sure.
Oh, by the way, we have your picture up on the screen over here now.
Okay. So they usually correlate pretty well. By definition, if you have MGUS, you have to have less than 10% plasma cells in your bone marrow. Smoldering myeloma, one of the criteria is plasma cell percentage greater than 10% in the bone marrow, as long as there's no evidence of any myeloma-defining events. So that's anemia, high calcium levels, kidney dysfunction, or bone lesions. And then there's a relatively new set of 3 new criteria that also are requirements to consider treatment. And those are patients who have bone lesions detected on MRI greater than 5 millimeters, even one single bone lesion. If the plasma cell percentage is greater than 60%, that's also considered potentially an indication for treatment. And then if your involved free light chains are greater than 100 to 1. So smoldering myeloma is when the plasma cell percentage is greater than 10%, or the M spike's greater than 3 grams per deciliter. But usually there is a fairly good correlation between the M spike and the plasma cell percentage.
Right.
If you have anything else to
No, absolutely. And so, especially in this early phase, there's a good correlation between what is the level of the spike and what is the percentage of the plasma cells. Later in the disease, and we'll possibly talk about this more later, sometimes there can be a change in the spike or no change in the bone marrow. Sometimes the plasma cells will build up and the myeloma cells are not making protein anymore. So that can be a bit confusing later in the disease. But early on, they tend to go in parallel. And also, when we're monitoring to see if you might need treatment, we will typically check both, you know, the level of the spike, and then also might have to repeat the bone marrow. Yeah. Okay.
Next question.
Oh, thank you. Many of us here, I'm sure, are on Revlimid maintenance, and hopefully for a remission that'll last a long time. But eventually, for many of us, the monoclonal protein numbers or free light chains will start rising slowly. How would you decide on whether or not to use a Revlimid-containing regimen for treating relapse in a situation like that?
So if you've been on Revlimid, right?
Yes, and it's working, and then the numbers start going up slowly, right. and then what? Right. You know, is Revlimid with something perhaps available for relapse?
Sure. So this is obviously a good and pretty common question. Maybe I'll take this one first. And so typically people would be on Revlimid maintenance, 5 or 10 milligrams possibly. I guess some people take it every day, but I use it 3 weeks out of the month, so 3 weeks on and 1 week off. And so The first question that comes up is if you're taking the maintenance, maybe 5 or 10 milligrams, obviously a higher dose could work. This is one option. Another option which we use pretty commonly is to add in dexamethasone, so that instead of just taking the Revlimid by itself, you could take that dexamethasone 1 day a week. And it doesn't need to be a massive dose. I'll often use like 20 milligrams or even a lower dose, and you can add that in to recapture a response. And often that's enough to do the job, even for a fairly long period of time. However, if you're getting a steady and persistent increase in the spike, many times it's clear that the Revlimid is just not doing the job. And so then you have another couple of choices. One is to add in another drug with it, and we have several of these combos that you're probably familiar with. You could add in what have been popular recently by mouth, Activism, which is an oral form of Velcade. You can do that. You can add in elotuzumab is another one that you can add in. So you have a number of options. You could add in daratumumab, but then we would tend not to do that unless we felt like there was really active disease. And then beyond that, you've got the next level is where you might switch to something different. You might say, okay, Revlimid, we've given this a pretty good run. Maybe we should completely switch and go over to the Velcade types of drugs. So you can see right there that this is the sort of thing that can burn up quite a lot of time in your office,
Right.
talking through what in the world are we going to do here, yes?
I think that's a very common scenario. A lot of patients are getting Revlimid post-transplant maintenance. I like to differentiate, first of all, what kind of relapse someone's having. So if you're in a complete remission and then you have a appearance of an M spike or you become immunofixation positive, that doesn't necessarily mean you immediately need to make a change. You could potentially watch that fairly closely for a while and see what the trend is before making a decision. So it doesn't automatically mean if you become positive, you need a change in treatment. So sometimes you can carefully watch patients before you make a decision about what you need to do. And then I like to differentiate between what kind of relapse someone's having. Is it purely biochemical, meaning just on blood work, or is it an active relapse, meaning you're actually developing a new bone lesion, you're becoming anemic? That's less common in the modern era where we're monitoring patients closely, but we do see it. And those are definitely patients you're probably going to want to change their treatment completely. Like Dr. Jerry said, patients are having a slow biochemical relapse. There are various things you can try, as he mentioned, such as increasing the dose or adding dexamethasone, or sometimes adding an additional drug to the Revlimid. So I think the important thing is to differentiate what kind of relapse you're having.
Right.
Okay, back in the
Okay, good.
back of the
All
room,
right.
number 3.
All right.
I'd like to go back to what you said a few minutes ago regarding using a 3-week regimen of Revlimid
Yes.
versus the 4. My wife is treated in New York 9 months out of the year. Her doctor there has a 4-week protocol. Doctor down here that she sees for 3 months has a 3-week protocol.
Interesting.
Now, what does I spoke to the ladies that are here representing the pharma companies, and they're well aware that the doctors have the discretion
Sure.
and do all the time. But at a potential savings of $50,000 a year per patient,
Right.
what's the difference between getting 3
Okay,
versus 4?
so as I indicated, and I'll be interested in Warren's perspective, but as I mentioned, my preference is certainly to go with the 3 weeks on and the 1 week off. And in the longer term, this becomes, it's certainly sufficient in terms of getting the benefit. I have no doubt, and most of the trials use that, the trials that we use to base our recommendations on, did use the 3 weeks on and the 1 week off. So we know in terms of benefit, it's sufficient. In terms of the side effects, that 1 week off, I think, is especially important in terms of your blood counts on an ongoing basis, both the white count and the platelet count, but also some other toxicities and what we call the GI toxicities. Some patients can have some problems with diarrhea and other kinds of side effects that emerge when they've been on it for several years, possibly. And so I think that the 1 week off is, I think, my top choice, and I would recommend that. And as you say, it's cost effective.
Right. I mean, I agree. I mean, I think if you're a purist, some of the maintenance trials post-transplant were done with continuous therapy, and that's probably where that comes from. But I agree with Dr. Jerry. I think most of us use the 3 weeks on, 1 week off from the perspective of recovery of blood counts. And, you know, in the relapse setting, we use 3 weeks on, 1 week off. So I think, you know, in most settings, I think most patients, you know, 3 weeks on, 1 week off is probably very reasonable.
Thank you, Doctor.
Next question?
Okay.
Dr. Dury, Dr. Brenner, and all the faculty, Susie, thank you for coming to Boca again. We really appreciate it.
The money that you sent me helped.
My question is about an article I read recently about a phase 3 clinical trial where daratumumab now being tested to be used sub-Q. And the article indicated that it was as effective as IV, and it seems to me that could be somewhat of a game changer for someone to not have to sit through infusions. I would like your comments.
So, Dara sub-Q?
Yeah.
Yeah, yeah. Yeah, so I think in summary, being able to give daratumumab subcutaneously, sub-Q, I think is definitely going to be a game changer. And so the comparative trials have just been completed, and about a month or so ago, Genmab, who works with Janssen, they submitted their request to the FDA seeking permission to register, you know, the sub-Q method. And so I personally think that this is going to be huge. The preliminary data indicate that if you take the Dara by sub-Q, it works just as well. In fact, in the comparison study, it actually looked like it worked marginally better, giving the sub-Q versus the IV. And of course, the IV is just so cumbersome, especially with the initial infusion, and then with the infusion center time coming in to get that IV is very cumbersome for everyone. And so I think for a lot of reasons, the Dara sub-Q is definitely going to be, as you say, a game changer.
Yeah. I mean, the only thing I'll add is until that makes its way to the mainstream, you can get Dara over 90 minutes after you've completed your first 2 doses. So I think a lot of centers are still giving it over 4 hours or 5 hours, but after you've gotten your first 2 doses, you can get a 90-minute infusion. So until the sub-Q becomes, you know, more available, you know, just make sure your physicians are aware that it can be given over 90 minutes.
Yeah, I fully agree. That's made a big difference.
Right.
But I think that the approval will happen rather quickly because one thing about the FDA is that they are on the patient's side. Sometimes it maybe doesn't seem that way, but but if they see something that will have these kind of impacts that will benefit the patient, and there's not a safety issue, which there is not in this case, they tend to move fairly quickly for approval.
Alana?
I just have kind of a general question about the treatment. Is the behavior
You
usually...
speak it up, yeah, so everyone can hear.
Is the behavior usually that you're taking a treatment and that it works for a while and then it kind of quits working? I mean, do people have relapse while they're on treatment or a refractory response? Is that true with most of the treatments?
You can relapse on
I mean,
treatment?
is that the expectation?
I mean, I think that's going to be the picture for the vast majority of people. So we do think for the vast majority of people, this is going to be a relapsing disease where patients respond, relapse, respond, relapse. There's definitely a group of patients who look like they have, you know, good long-term outcomes without relapse. This is typically in the transplant setting, where there are some patients, you know, probably up to 15, 20%, where they're out more than 12, 15 years without relapse. But in general, for the vast majority of people, myeloma is going to be a chronic disease with remission, relapse, remission, relapse. And ultimately, you know, we do think that with each relapse is not good in myeloma. So with each relapse, you know, the remissions tend to get shorter on average. And with each relapse, those remissions may shorten. But that is a general principle in myeloma.
Yeah, so one of the main things I would add on to that is that there is a change in perspective now related to relapse. In the past, we would give our first treatment, and then there could be relapse, and then we're kind of scrambling maybe just to do the best that we can. But now we have, as I was mentioning earlier in answer to the first question, that we have a lot of options for relapse. And now we have some really, really good options for relapse. And so I think the big thing now is to look at a more decisive treatment for relapse. In other words, we're not just looking to maybe get the protein back down, we're looking to say, okay, what would be a good way or the best way to get a next long remission? And so this is based on the results with combinations like daratumumab, Revlimid and Dex, or daratumumab, Velcade and Dex, where when those drugs were being tested in the relapse setting, patients were not only having excellent responses, they would get what is called this minimal residual disease negative, where they were getting fantastic responses and really having substantially long remissions. And so I think that this is an important discussion to have with your doctor is, okay, we could give you Revlimid and Dex or pomalidomide and Dex, something very simple, which could be good depending on the situation. But if we want to do a stronger job, you know, we could use a 3-drug combo and maybe look to achieve something more.
Right.
Okay, right over here.
A little change of pace for a moment. The ASCENT trial has been
Yes.
open just for a few months.
Right.
Do you know how participants are tolerating treatment?
Okay, so this lady is referring to a trial called the ASCENT trial, and this is a trial for patients who have high-risk smoldering myeloma. And so this is a subgroup of patients with smoldering myeloma who are kind of in transition to active myeloma. And those are patients where the myeloma protein level is greater than 2, where the bone marrow percentages are greater than 20, and where the free light ratio is greater than 20. So it's a subset of patients who have a higher level of smoldering myeloma. And the treatment consists of the combination of daratumumab, Kyprolis, Revlimid, and dexamethasone. So it's actually a 4-drug regimen. So this is similar to what I was just describing. This is a very decisive approach to see if you can get the maximum benefit with a strong combination early in the disease. And so thus far, 12 patients have been treated in this trial, and the treatment has been going unusually well. There have been no unexpected problems. The treatment has been well tolerated, and patients are continuing on treatment. The first patient is about 6 months out at this point and has in fact achieved minimal residual disease negative status, which is the goal of this study, to treat early and get them to no evidence of residual disease at an early time point. So I would say we're very pleased. It's going well. And so I think that this is the decisive approach. It's not for everyone, but if you feel inclined to consider it, I think that it's going to be a successful study.
Number 4.
Hi.
Hello.
Whether it's the disease or the drugs, I don't know, but I'm exhausted a lot, and a lot of my co-patients in my support group experience the same. What can we do about that?
The co-pays?
No, exhaustion.
Oh, it's exhaustion. Oh, oh, yeah. Well, really exhausted. Yeah. Well.
But if you want to help with co-pays, you know, you're on.
The exhaustion. There are a lot of different kinds of exhaustion, and I think that truthfully, it's a difficult one to deal with. I mean. Physically, you know, when you've been on treatment for a long time, you know, there's a psychological exhaustion that kicks in, you know, which can be hard to overcome. And then there's the physical exhaustion that comes when you've been on a lot of different treatments over many years. I mean, these are situations where you really need to come together. Actually, it's one of the helpful things about meetings like this, where, you know, you can get a lot of tips about how to manage those longer-term things. You know, find out what did you do when you were on this treatment, try to do the best that you can, tips to do better and to get support to work through issues. And sometimes just to know that when you're starting on a new treatment, it can be bad at the beginning, and then it could be better later. But it is a difficult issue, both the physical and mental exhaustion with the disease. In the old days, when it seemed like it was linked to anemia, so of the things related to myeloma, what can cause exhaustion or fatigue is anemia, but frankly, we don't see as much of that anymore, and we don't really have that option to manage that part of it. And so, any tips about fatigue?
Yeah, I mean, I'll add a few things. I think it's important to rule out things that are reversible. Revlimid can be associated with thyroid abnormalities, so it's important to make sure your thyroid's okay. Like Dr. Jury says, things that are fixable that we can do from an anemia perspective, ruling out other things that could contribute to fatigue, and then exercise is very important. So at Lung Cancer, as part of our group, we actually have exercise protocols for patients who are receiving anti-cancer therapy. So sometimes exercise is the best thing you can do for fatigue. I know it sounds kind of contradictory, but you know, the more active you are and the more you exercise, often you know, that helps with fatigue. So that's an important part of cancer treatment in general, is trying to stay as active as you can and as physically active as you can. Those are things you can do as a patient that may help.
So we also have, the IMF has a booklet on fatigue, and Debbie Burns is back there. Debbie, do you want to make a comment? We have a booklet where we do try to help with fatigue.
The booklet might be helpful.
Why don't you use the mic?
Well, yeah, speak up, yeah.
The booklet, Understanding
Why don't you use the mic?
Myeloma-Related Fatigue,
Yes,
might be
understanding
helpful.
fatigue.
I will bring you one right now.
All right.
There are a bunch of them at the
Do you have any tips from the booklet that we could mention?
Well, one thing to think about is what other medications are you taking? Because a lot of medications in their own right that are not treating your myeloma, but maybe treating your high blood pressure or another comorbidity, another problem that you have, could contribute to the fatigue. So you have to make sure that you're not compounding the problem.
Yeah, this is
meds.
actually a very, very good thing. I mean, many patients with myeloma have other medical problems, high blood pressure, diabetes, heart disease, and not only those diseases, but the treatments for those diseases can be causing fatigue or other problems. But again, it is something to talk to your doctor about and try to work through and see what can be done or what might be the primary cause in your case.
Yeah.
Hello there.
I've been battling this fatigue problem also for 1.5 years, and I found one of the best remedies is being in social contact with my friends. And I've been very forthright with them and told them about my condition. And I said, they asked me often, what can I do for you? I said, call me or let me call you and let's go out and do something. And just this, or they come and visit me. And just the social action gets me out of fatigue a lot. Right.
Great suggestion. Yeah. Have them take you out to dinner. Yeah, there you
go. Right now I'm on Pomalyst Dex and Coumadin, and I'm scheduled to get a hip replacement done next month.
Okay.
So the doctor did express concern about the Coumadin, backing that off. Is there any other issues that I should be concerned about with this procedure? Hip replacement?
Well, you want to comment first?
Why are you on Coumadin?
Well, I was on Revlimid after my stem cell, and I had a blood clot.
Okay.
And they put me on the Coumadin.
Right.
Now, this was about 8 years ago. So they took me off the Revlimid because it wasn't helping me, and I was on Velcade for quite a while. And now I'm on Pomalyst, but I'm still on the Coumadin.
Right.
And I guess that was another question. Do I still need to be on Coumadin since I haven't had an issue except that one time with the Revlimid?
These are for sure key questions. So for the Coumadin, you guys probably know is a blood thinner. So you could also understand that could be a problem if you're having surgery.
So, you know, when you had the blood clot on the Revlimid, you know, that was an appropriate therapy. Once you had come off the Revlimid and on the Velcade, I'm not sure you needed to stay on the Coumadin. Now it's a little trickier because you're on a drug that also can cause blood clots.
Yeah.
So it probably wouldn't be a good time to take you off it permanently.
Right.
But I think it would be safe for you to come off the Coumadin briefly for surgery, be adequately prophylaxed post-operatively, but because your blood clot was 8 years ago, you're probably at relatively low risk of developing a blood clot, if you come off the drug for just a short time period.
Yeah, they mentioned that, but I mean, is there any other issues with the surgery, with the multiple myeloma? I mean, is it?
So maybe
is the Coumadin the only
a
concern?
couple of quick comments. So certainly the Coumadin issue needs to be carefully discussed, and you can be covered with, there's another medicine like heparin, another type of blood thinner you can use just to cover post-surgery, because classically there can be a problem with blood clots after hip surgery, and so I mean we can't be too cavalier about this, but we need to get you off the Coumadin for the surgery for sure. But the other thing is, how about the Pomalyst? Well, I think that it could impair wound healing, and personally I would recommend taking a little short vacation on the Pomalyst as well for 2 or 3 weeks post-surgery, just to allow good wound healing after the surgery. So extend the 1 week off to maybe 2 or 3 weeks, just take a short break for therapy around the time of the surgery.
Agree.
Okay, thank you.
Okay, Ilana?
Yes.
Genomic sequencing. How important is it in
Genomic
choosing your
sequencing.
regimen?
I'll let you take this one.
All right, well,
That's a loaded.
do you want to answer that one, or you give your 10 cents and I'll give my 10 cents? Okay.
I mean, I practice in a community setting, so it's a little different from an academic setting. I mean, I think there's standard tests that we need to do to know about the genetics of myeloma. So I think the standard is what's called metaphase cytogenetics, which are usually not informative in myeloma for most patients, meaning usually they're normal. And then something called a myeloma FISH panel, which looks for the common deletions or translocations that we see in myeloma. I think that's still the standard of care outside of a clinical trial, that we need to risk stratify someone's myeloma and may or may not influence how we treat someone. I think genomic testing, or using something called next generation sequencing, which is looking at many different types of genes, and there are different companies that do this. I think that I seldom use it outside of a clinical trial setting, because I don't really know how to use the information for most patients. So I don't think it's really standard right now, but I'll defer to Dr. Dury if he has any other points.
No, we fully agree. I think that this FISH testing is quite helpful. We like to do that at the beginning. I think that's appropriate. And then also at relapse, we might repeat it. And we're looking to see if there are some of the changes that we classify as high risk, things like 414, 17p, 1q plus, so, several of those that we say, okay, it's basically like a red flag for us, where we know that maybe the treatment would not work as well, or maybe not give such a long remission. But truthfully, we don't have a clear, different protocol that we would use. In other words, if we get those test results, typically we don't drastically change the treatment, because we don't really know what to do differently at this point. So it's more of a red flag. And then as far as more detailed, these genomic testing, where you do the whole sequencing and look for all the different mutations, I think that we fully agree. I mean, I think that this is interesting for research, but right now we absolutely don't know what to do about that. And the main reason is that there are a number of different mutations. There's not just like one mutation. And so one of the things that you hear about is something called precision medicine, where someone says, okay, oh my gosh, we found this mutation over here, we're going to give treatment for that. Well, the problem is that there's a half a dozen other mutations sitting over here, and what are you going to do about that? And so this, I think, for now is conceptually sort of a flawed idea, in that we don't really have an adequate follow-through as to how to deal with multiple mutations. And so for that reason, I don't think it's worth getting a rather expensive test.
Okay, question right here.
Back to the Revlimid maintenance question earlier, you talked about 28 days versus 21-day treatment, but then you also kind of alluded to 5 milligrams versus 10 milligrams versus maybe 15 milligrams. Is there any science in any of this that determines how many milligrams for how many days?
You're saying we're not using science? Yeah.
Usually if you have normal kidney function, we would start at 10 milligrams. And that's based on the clinical trials that were done with a ramp up to 15 milligrams if it's tolerated well and there's not any significant drops in the blood counts. I find that quite tricky. I don't normally do that commonly because I think a lot of patients do have problems with their blood counts post-transplant with higher dose Revlimid. So I tend to stick at 10, and sometimes patients do require dose reductions down to 5 milligrams if they have problems with their blood counts. I try not to go lower than 5.
Right. A key kind of a science part to this that we do know the answer to is that staying on the maintenance is beneficial. So if you can reduce the dose and reduce the toxicities and you can stay on the maintenance, that's better than stopping it. And so those adjustments down to 10 to 5 milligrams, I do that very frequently so that I can maintain the maintenance. Now, the other thing is that over time, you learn that as you're making those adjustments, some of those lower doses have important benefit on the myeloma. And so I now know, after treating so many patients, that 10 milligrams, 5 milligrams, these lower doses, they are significantly active against the myeloma. So those are not trivial doses. And so even if we lower it to 10 or 5 milligrams, we know that those are providing benefit.
Okay, Brando, number 3.
Can you just give an update on what the latest is with the MRD testing? The last time you were sort of recommending that it didn't matter whether that much. So I'm just curious as to what your recommendations are.
So I'm going to be talking about MRD testing tomorrow, but I can give the capsule summary. So the main point is that there are 4 reasons to do MRD testing. So obviously, if you do the test and it's negative, that's a good thing. So that's called a prognostic use. So it's good to be negative and it's not so good to be positive. The second one is where it would be used in a trial to say, oh, if the trial is showing MRD negative, one treatment is better than another. And this is a much more decisive use, and this is one that actually the IMF is pursuing, and we are meeting with the FDA, and we're involved in submitting results from all kinds of trials to see if the FDA will accept it as a trial outcome. And we're pretty optimistic about that. The third way that you can use it is where you're going along and you're taking your Revlimid maintenance, and then you do the MRD test and it's negative. So then what are you going to do about that? Are you going to stop the treatment, maybe continue the treatment? So decision making. And for me, this is a tricky one. I don't think we know the answer to that, and we need more trials. And then the fourth thing is as an endpoint in these cure trials. So this ASCENT trial, the goal of the ASCENT trial is to get all the patients as deep as possible and get to MRD negative. So it can be used as an endpoint within a trial. But as far as running it in my office, just for prognosis, I think it can be reassuring, but I'm not sure that one truly needs to do that. I don't know.
I mean, I'll give the community perspective, because I think most patients are probably treated in the community rather than clinical trials or academic centers. So, I mean, I don't do MRD testing outside of a trial. I think the other thing I wanted to mention is, there's different ways of doing MRD testing, and we don't really know which is the best way. Sometimes it depends on the individual center. Some centers have particular expertise in doing a certain way of testing for MRD, and another center may do it another way. So we have to also figure out what the best way of looking at MRD is. I think that's a big issue. And like Dr. Jerry says, I think the main thing is we don't know how to use that on patients who are currently on treatment. I think in a clinical trial, it's obviously an exciting avenue that's being pursued. And we know that prognostically, if you're MRD negative, but it also depends on how MRD negative you are. You can be, 1 in 1,000 cells, 1 in 10,000, 1 in 100,000, 1 in a million. So obviously, the more sensitive the test, and if you MRD negative at a very sensitive level, that is probably a good thing.
Right. So, yeah, I think it sounds like we're both agreed. So I don't routinely recommend it, outside of a trial. But it is going to end up being used once we have answers, more answers.
Michael?
Yeah.
Thank you. I think we've been talking a lot about the changes, people being treated, then relapsing, then treating again, relapsing, but I'm coming from a different angle, and that's for smoldering myeloma.
All right.
So for people that have, I guess it would be called standard risk, the FISH standard,
Yeah.
none of the mutations, etc. We keep hearing and I keep reading about how if for every, like beyond 5 years, for every year that you haven't progressed,
right,
the chances of progressing are less. But I'm wondering, because I've heard of some people that have smoldered for 10 years and then have gone on to develop
right.
CRAB. Is that still look, I don't expect anybody
Right.
out there to have a crystal ball.
Sure.
But I just wondered because it's confusing, and then if one is being followed every 2 months, will that be every 2 months for the rest of our lives? Hopefully, as we keep smoldering,
Right.
we don't progress.
So this is a very important question, and actually increasingly common as we're diagnosing MGUS and smoldering earlier. So we're more and more patients like yourself who have these concerns. So the first thing I would say is that the percentage chance of smoldering turning active, it hasn't changed. It's 1% per year, and so that really doesn't change in the broad sense. However, what we're actively looking at is, are there features in an individual case that would change that percentage? And so one that we think could be important is the presence of these FISH abnormalities. If you have abnormalities, that possibly changes the percentage a little bit higher over time. And maybe some other features. But mostly we're looking at new tests to guide us, because clearly all the different testing that we have right now is not helping us that much. And so one test that we're looking at, which is a whole new concept, is that when myeloma is active, we actually find myeloma cells in the blood. And so this is using basically the MRD test that we were talking about. If you do that test and look for myeloma in the blood, and you actually find myeloma cells in the blood, this is an indicator that the myeloma could be turning more active. And in the initial results, we find that this indicates there could be a relapse or progression within 6 to 9 months if you actually have myeloma in the blood. So we're looking at new testings like this that could help to guide us. And this test could be done, by the way. In your case, if you wanted to do that right now, a sample could be sent to the Mayo Clinic. They accept outside samples, if you wanted to do that. I think, yeah.
I want to thank Dr. Drury and Susie for having this. I look forward to it every year.
All right.
My question is, if I keep running fevers, like 100 degrees, no infections or anything. And this has been going on for 2 years. And sometimes it puts me in bed, I feel so lousy. Do you come across that very often?
We don't see that very commonly,
No.
without some other underlying
Yeah.
cause. Usually sometimes it can be a manifestation of myeloma, but going on for years would be a little unusual. I haven't really seen that. I don't know if you
Yeah,
have.
because that's what they said, it's just connected to the
Right.
myeloma. And I keep taking Tylenol all day, and I don't like doing that, to breaking it, but.
Right.
But I want to thank you again. I appreciate it.
It's always good when something's been going on for a long time.
Yeah.
Brando?
Can you talk about vaccines and whether they're effective if you're on 20 or 40 of Dex a week as part of the maintenance?
So you're talking about regular vaccines, like the flu vaccine, or?
Post-transplant. The Pneumovax,
So
Prevnar.
do you want to comment on that? You want me to comment on that? We're like, oh, do you want to comment on that, or should I?
Because it's very variable. Some doctors say it's
Yeah.
worthless, especially if you're on steroids. It may not even take
Right.
effect.
Personally, I think it's a really close call. I mean, the standard guidelines post-transplant is that you would attempt to revaccinate. But this has become quite complicated because many times patients are on Revlimid maintenance, and the benefit is possibly going to be much less or minimal or maybe none at all. And so I think that It's really a close call. I have some patients where we've done it and some where we haven't. The one thing I would say, which is the practical thing, is, you know, we're vaccinating against, you know, tetanus and mumps and this one and that one. I mean, I haven't seen an outbreak of any of those in my patients. And so from that sense, it's not as if I'm treating something where there has actually been a problem.
Right. The only thing I'll add is there is some data in myeloma patients that the influenza vaccine could be repeated 4 weeks after the initial vaccination, including the high-dose vaccine, and that's been shown to be of additional benefit in myeloma patients. So I do tend to do that, is get a double flu vaccination, because influenza is probably going to be the most common vaccine-related infection that we see in myeloma patients, and it can be serious in patients with myeloma.
Right. So this is the practical point. All these other vaccinations, I'm not so sure. Okay.
Michael?
Thank you again for coming year after year. We sincerely appreciate, because we learn and we share so much with you, the doctors, with the patients, with the caregivers. We're learning and sharing, and that's so important. My question, in patients with a T1114 translocation, are you using venetoclax, and with what success?
Okay, so this lady's asking about one of the FISH test abnormalities, which is called 1114. And strangely, this is one which is considered to be more of a good risk feature, although we are reevaluating that. But basically, it's good news. But the second piece of good news is that we do have this new drug, which is called venetoclax, which specifically works in this type of patient. And so this is excellent. And so up to now, there have just been trials. And so there's been a trial with venetoclax.
For lymphoma, but not for myeloma.
It is, right. So this is an unusual situation where this particular new drug, it's not approved for myeloma, but it is approved for lymphoma. So technically, it is available, and I know some patients have been taking it. There is an ongoing series of trials with venetoclax plus Velcade, and those results have been good, although there was a recent alert about that. So I'm not sure if there are any concerns about that combination. So, but basically, this is good news. This is it's a new drug, and we're hoping that it could be specifically helpful for the 1114.
I've treated quite a few patients with venetoclax, and I use it either Velcade as a partner or Kyprolis. There's data to support both, and the data with Kyprolis actually looks quite good. So, you know, we are using it, and it is NCCN compendium listed. So, usually we haven't had a major problem getting it covered by insurance companies, so, which is a practical reality. So,
right.
Yeah.
So it's a bit unusual, and in fact, we don't know if how actively the company is pursuing FDA approval. But I mean, you can use it in the meantime. So.
Right.
Thank you.
This gentleman right here has a question.
Okay.
Thank you. Recently, we canceled a trip to China, Japan, because our doctor said, you know, maybe you shouldn't go over there. Everything's normal. Our counts are normal. We have no issues much, but he was just nervous about it, and so we canceled. What do you think about your patients when they come to you and want to go traveling?
Well, I think mostly traveling from the medical perspective is okay, and we can handle it. I think that Japan and China, I think that we could definitely get you some good doctors there who would check up on you. I would say that Japan would be a little bit safer. The Japanese have wonderful hospitals, wonderful doctors, and you could go in and get good consultation and care if you happen to need it. China, maybe not so much. We go to China quite a bit, and when we go in to give our meetings and lectures, you walk past a clinic which is called the High Fever Clinic, which doesn't give you...
But Brian, they're not going there to see the doctor. They're going there to see China.
It doesn't give you great reassurance as to what's going on in China.
It is a little horrifying when we do go into the hospitals there, but I we go to China often, go. It's fabulous.
Yeah, it is. I
Don't
think
listen
that-
to the doctor all the time. I certainly don't.
Yeah. So, no, and I mean, and we talk about it all the time in the broad sense is that, you know, one of the reasons that we want you to be in remission and doing well is to do some of those things that you've always wanted to do. And so I think it can be done, and I think it could be done safely.
Yeah, absolutely agree. As long as the only time I recommend my patients don't travel is if I'm just starting them on a new treatment and I want to make sure they're tolerating it okay. I wouldn't start a new treatment and then send someone to China. So I think as long as you're stable on your therapy and myeloma is doing okay, I would have no problem, you know, having my patients travel, and they do it all the time. So
yeah,
My cat's traveled all over the world,
yeah.
and he did just fine.
Right.
Yeah.
Okay.
Hi. You mentioned earlier that when you're treating some of your patients that have issues with anemia,
right?
How are you treating those patients? I'm currently taking Kyprolis and Dex. What would you do because I have that issue. What
Right.
would you do in my case?
Yeah, so the anemia part, I don't know what you're doing in your practice right now. It's become quite tricky. I mean, we used to use these medicines to boost the red cells, but we basically stopped doing that because of concerns about the question that there could be secondary side effects, including cancer and other kind of problems that would emerge if we give you the medicine to boost the red cells. And so now we tend to more adjust our treatments, which would allow your hemoglobin to come back up naturally. And so our management of that has changed a little bit in the last 5-10 years, I would say. But what's your experience?
again, we always look for reversible things, you know, make sure iron levels, B12, folic acid, all those things are okay. And I agree with Dr. Jury, we tend to use less drugs such as Procrit than we used to because of this concern that we had seen about potentially a higher risk of secondary cancers. But in patients who have symptomatic anemia, I do use it, but we use a much lower target. Before, we used to try and get the hemoglobin up to normal levels of 12, 13. Now we just try and get it to a level where a patient is less symptomatic and doesn't require blood transfusion. So if we get that level up to 9, that may be adequate, or 10, and we seldom give those injections if the hemoglobin's above 10. And we think that's probably, you know, going to be relatively safe. So, you know, understanding there is some data out there that it could be of some concern. But I think if used appropriately in the right setting, it's something that can be done.
Okay, doctors, it's a speed round now.
All
We got
right.
them all stacked up like planes over Newark. Brando.
Okay. Yes.
Okay, I'm wondering what your experience has been about a treatment with like RVD, the dosage relative to the resulting peripheral neuropathy, and whether peripheral neuropathy can be expected on a maintenance program with Revlimid.
With Revlimid, no.
No?
Well, RVD was the first part, yes?
Yes, yes,
So
and so-
obviously, using the RVD for induction, we watch very closely for neuropathy, and now I suspect you do the once a week and subcutaneous. But if you use the once a week subcutaneously with the Velcade, we really try hard to minimize the neuropathy. The big thing about neuropathy is to try to avoid it, you know, because once it develops, you know, then we have to manage it, which is not so easy. So the most important thing is to be extremely proactive. Now, Revlimid is not typically associated with neuropathy. However, I guess I do see patients where they do report some degree of neuropathy with ongoing Revlimid. I don't know what your experience with that is.
Yeah, I mean, I think if you look at the package insert, there's a very mild increase, but I think it's something that we don't see very often clinically. Again, you know, myeloma itself can be associated with neuropathy. So, again, Revlimid by itself shouldn't be a major issue for most patients.
So is your experience that it's more associated with Velcade?
Oh, yeah.
Yes.
Okay.
Yes.
All right.
Absolutely. Yeah, so if you transition from the VRD to the Revlimid maintenance, you should be okay. Maybe some minor effects, but I haven't seen too much trouble. Yeah.
Okay, Michael, you're up.
Hi, I'm
77, quite fit. I was diagnosed 3 years ago. I have been on Revlimid and dexamethasone ever since. I'm down to 5 milligrams of Revlimid and 8 of Dex.
Okay.
I'd like to stop the Dex,
Okay.
but I'm not sure if it makes sense to stop the Dex.
And maybe your partner would like you to stop the Dex.
Now, I know there was a European European study that I had a look at fit individuals of my age that stopped the Dex, and they seem to do well.
Well, good.
But I would like to extend the relapse, so it's...
Sure. So a couple of very important points there. So in the maintenance phase, mostly we do use Revlimid by itself. So I am comfortable to kind of taper down and get off of the Dex. And so what this gentleman is referring to, there was a presentation at our American Society of Hematology meeting in December, a study from Italy where they looked at patients where they did stop the Dex or not, and the patients where they stopped the Dex did just fine. And so, in fact, even did a little bit better. I think partly because they were able to stay on the protocol without the Dex. And so, so I would certainly be supportive of targeting to get off the Dex.
I agree. Yeah.
Yep. Okay, go ahead.
Hello. I know it's always good to get compliments, and we are here for about the 4th or 5th year in a row. And we want to thank Susie and the docs for all you do for patients and caregivers.
Well,
thank you very much.
Thank you. Thank you so much. It's our pleasure. I mean, that's what we're here to try to do, is to help.
Well, the group is fantastic for helping everybody move forward with the disease. My question is about hereditary factors. What's the thinking now? My wife has myeloma. Her father had myeloma. We have 4 children, and we just wonder how deep into studies and lab work should our children be getting. Thank you.
All right. Maybe say what you would do and, you know, in practice about that, would you?
Yeah, I mean, I think in general, we don't think myeloma is a hereditary condition. There may be some families where there's some kind of mild signal, but in general, we don't think it's hereditary. So I probably would not recommend, you know, specific testing for your children. I don't know if you feel.
Right. No, so right now we don't have any genetic testing that we can do. So we can't say, oh, well, you know, we found there's this gene that's, no, we don't have that. The only thing that I will often recommend is to have family members who might be concerned just have a testing, which is fairly easy, where you can have them get the basic testing, which is a protein test, SPEP, UPEP, and a free light test, which will basically diagnose 99% of myeloma. So that with one blood test, you can make sure that people in the family, you know, don't have a problem. And then you could repeat that periodically, you know, every 5 years or something like that, you know. So there is a sort of an in-between strategy where you kind of keep an eye on it, which I often do when there's a level of concern. Yeah.
After 8 weeks of induction for a variety of reasons, including my doc said, oh, we can do stem cell later.
Yes.
I did not do it at the time, and I've been on maintenance, and I'm wondering what things might indicate it would be a good time to go back and do that.
Okay, so this is one of the $64,000 questions. Should I do a stem cell now or later?
Right.
Okay, so for 10 points, so the reason that we sort of are questioning it is that the data are kind of mixed on this, in that There was a large study that has been done and was reported where half of the patients got the transplant up front and then half of them didn't. And so the outcome of that study, a French study, was that the remissions were longer in the patients who got the transplant up front, but the overall outcome ended up being the same so far. So the survival was the same. And so the current recommendation, which was just reviewed, there was another review article in our magazine Blood here recently where there's definitely an option. It seems that if you're monitored closely and you do the transplant later at a point of relapse, you can possibly recoup any overall survival benefit. And so it's kind of an open question. I would say that in my own practice and recommendations, for a younger person, I would normally recommend to do it unless there's a strong objection, because it really does have excellent outcomes, but you probably lose little or nothing if you delay it. The only situation is that if things change so that maybe you can't do it later, then you might have missed an opportunity, and so that's always something to think about. But that's my take so far.
I see this commonly. I think the one thing I would add is maybe this is where there is going to be a role for MRD testing in the future.
Mm-hmm.
Maybe if someone's MRD negative after the induction, we may feel better about those patients not being transplanted up front. Again, that's a research question, but I think that's going to be an important role for MRD. And I'm facing that situation with a patient right now who elected to defer transplant. They were MRD negative after their induction. Because it looks like if you become MRD negative, that's a good thing no matter how you get there, whether you get there with or without transplant. So I think that may be an important role for MRD testing in the future. But again, like Dr. Jury says, I mean, there are some patients, especially if you're older, you may lose the chance to get transplanted in the future just if with aging and other comorbidities. So that does have to be kept in mind.
No, but I fully agree. And this idea about the MRD, however you get there, very important point.
Okay, so I didn't realize that this goes till 1:15, 2:15.
Oh, so we have a few more minutes.
So guess what? I have a question over here.
Okay.
If you're on low-dose Revlimid every other day, do you still recommend a break down the road of 3 weeks? And my second question is, after a stem cell transplant, do you recommend getting revaccinated for the measles again?
Why are you on it every second day?
Right. That was my question too. Why are you taking Revlimid every other day? Does it reduce the cost or what?
No, it's, I'm in Canada,
cost.
so
No.
it's covered by, I'm in a trial, so it's covered. But it's my bilirubin spikes high, so they're attributing that to the bilirubin, I think, level rising. So I'm on 5 mil every other day for the last 2 years.
Huh.
Yeah, I mean, if you were getting it every second day, I'd probably just do it continuously is what I would probably do rather than a week break if you just every second day. As far as the vaccination, I just usually follow whatever the guidelines are for post-transplant vaccinations. So because I'm not a transplanter, I don't usually do the vaccinations myself. But
right. Yeah, I mean, I think the only comment on that is that we know for sure that those vaccinations in these situations don't work as well as they should, but many of the transplanters will go ahead and do them anyway, even though, you don't get the optimum benefit.
Okay. Judy?
Hi, I'm wondering if you're familiar,
Into the mic. Yeah.
if you are familiar with the PROMISE study out of Dana-Farber, and it is for children of people with multiple myeloma. If you are, what is their aim? What are they trying to do, and how are they doing it?
Right. This is a project where they're trying to, with the researcher Irene Gobriel, who's at the Dana-Farber there, looking at the African-American population. And it links in with actually one of the questions that we had. So the thing about myeloma and MGUS and smoldering myeloma is that it's more common in African-Americans.
We're not African American. So I don't think they were looking at African, my understanding.
They have a
I'm not aware of that.
They also had a study which might be where they were using, I think it might be the one where they're using elotuzumab Revdex for smoldering myeloma? Yeah, I think maybe it was that one, yeah.
She's got an IRD trial for
Hmm?
Irene has an IRD trial.
An IR, yeah, Ixazimib RD. Yeah, Ixazimib Revdex, yeah. Yeah, so there are actually a number of trials. I mean, this does raise some questions. You know, if you're going to treat smoldering myeloma, you know, what do you do? Do you use something like the ASCENT trial, which is a decisive effort to do a great job, or do you do something less than that, which almost certainly is not going to do a full job, and you know, what will it accomplish in the longer term? And so there are a number of trials like that, which in my opinion need to be thought about very carefully. Yeah, so she does have some trials for smoldering myeloma, and she has this other study which is kind of epidemiology among families with myeloma, African Americans with myeloma in the family. Yeah.
In the back of the room, Alana?
Thank you. Good afternoon, everyone.
Speak as loud as you can, yeah.
Okay.
Yes.
Yes. I was diagnosed with multiple myeloma last year.
Okay.
That was the result after almost 2 years of testing for fatigue, low blood count, and a number of other issues. And I started the treatment toward the end of last year, October. And the treatment includes Velcade, dextrostat, thalidomide, and it's a 4-week.
Thalidomide, is she? Yeah.
Yes. It's a 4-week on.
Yeah.
And 1 week off, and then you go back to 4 weeks again. But my question, during the process of going through this, or before I started it, one question I was concerned about, because I know persons who would have had any form of cancer, the hair would fall off. And that was the question I asked, would my hair fall off? Well, they said no. But it has been thinning out quite a bit. And I'm just wondering what you know, can be done about that, or what, I mean,
Okay.
how can you
So,
recover?
Did she had lymphoma before? Is that?
No, I don't think so.
No. So, yeah, I'm not sure if I fully understand. Did you mention that one of the medicines that you were taking was thalidomide? Is that what you said?
Velcade, dextrostat, thalidomide, yes.
And thalidomide?
Yes.
So VTD.
What's that?
So
VTD. Yes, VTD.
TD. Okay. All right. So this is an unusual one that we wouldn't frequently use these days, that's for sure. Yeah.
Okay.
Do you know anyone who would be using
No,
that?
I mean, you know, VTD is a regimen that we don't use that commonly in the US. So
Right.
I'm not sure there was a specific reason why your physician recommended thalidomide.
Right, right. It might be because you were very anemic. Sometimes we use thalidomide, well, occasionally I would say, if the blood counts are really low and we're concerned about giving Revlimid, which does knock down the blood count somewhat. But it sounds like maybe we could talk separately and try to figure out what has been recommended and why, and see if we can help you, okay?
Okay, question right here.
What is the cutoff age currently for a stem cell transplant?
I don't think there is a specific cutoff age in the U.S. I think it's based on fitness and other medical issues. I mean, I don't think there's a specific number that I'm sure 90 would probably be a cutoff number, but you know, I've had patients transplanted in their early 80s, so I think in Europe they may be a little stricter as far as the cutoff age for transplant, but there's no magic, you know, cutoff in the U.S. that I'm aware of for transplant.
So the only cutoff is for Medicare, and so they used to have a 74. Is it still 74?
Last I checked, I think it was 77.
It's gone up to 77? Yeah, so if you're getting reimbursed through a CMS Medicare, there's a cutoff. It used to be 74, but apparently now it's up to 77. Gives you some idea. In Europe, for some reason, they tend not to transplant over the age of 65, which is a little bit odd. But 65 to 75 is... hmm? Yeah. '65, yes, yes. So, but I mean, the reality is that you can actually do transplants for patients who are in good shape, almost irrespective of the age, if you're careful. Yeah. Okay.
Okay, Michael again.
If someone has had an allergic reaction to Revlimid, such as a severe rash,
yes,
would there necessarily be a cross-sensitivity with pomalidomide?
No, but I would sure be real cautious. I don't know if you've had that exact experience where you've gone from one to the other.
So it depends on how severe the rash is. Someone had something called Stevens-Johnson, which is a life-threatening rash where basically looks like a third-degree burn. I would not re-challenge with pomalidomide. If it's anything less than that, it's probably a reasonable thing to try, understanding potential risks and benefits. Pomalidomide is probably associated with less rash than Revlimid.
Right. No, I have used it, except for this really, really bad rash, the Stevens-Johnson. The other rashes often are improved or even eliminated using steroids, either prednisone or dexamethasone. So if that was the case, I mean, if the rash went away with dex or prednisone, then I would be more comfortable to consider the pomalidomide.
Okay, we have 5 more minutes.
I have a question for you. My doctor is recommending an annual bone marrow biopsy and PET scan. Is that necessary?
Okay, well, good question. Well, I think that for routine monitoring is something that we would consider, depending on the circumstances. My guess is that there's a pretty good remission that's been achieved, so no. Oftentimes with the myeloma protein, if the myeloma protein has gone to 0 or extremely low, it may be hard to know what is the status of the myeloma, and in which case you might need to do a bone marrow or a PET scan. Between those two tests, normally I might do a PET CT scan when the protein is very low to see what the status of the disease is. Normally, I would only do a bone marrow if there's an open question, if I was really thinking that there might be a change in the disease status. So I wouldn't link those two things together in my own recommendations in an automatic way.
Yeah, I agree. I mean, I don't do those tests routinely unless I think it's going to change management or someone's having symptoms that don't fit with what we see clinically. So if someone's protein levels are low, but they're having new bone pain or new symptoms that are concerning, I would do those tests. But if someone's doing well clinically and seems to be in remission, I'm not doing those tests on a regular basis. It's very unlikely to change management. So. Say it again? If someone's in remission,
Yeah, it's a restaging, which is something that you might do periodically, but what we're saying is that we just wouldn't do that as an automatic thing.
Right.
And we would mostly do it if maybe something was changing where we thought, well, let's just double check, see what's going on here,
right.
But not as an automatic thing. Yeah.
Okay, so evidently we're running out of time.
Okay.
But this lady just slipped me, so she gets time.
Thank you. I get the last question. Have there been any environmental chemicals or pollutants that have been implicated in causing myeloma? And should I be concerned about using things like Mosquito Squad and Camelona on my area?
Yeah, I noticed that's a concern. As we were driving in from the airport, I was looking out at the houses here, and I saw all those black nettings around the back patio areas, and I realized that is quite important here. So in all seriousness, there is quite a lot of data accumulating that different toxic chemicals can not only cause cancer, but can specifically cause myeloma. And a number of them, there is stronger and stronger what we call epidemiology data linking them. I'll mention 2 or 3 that have been in the news recently. The one that's been in the news most recently was with Roundup, the weed killer. And you maybe saw in the news, this was some months back, that a patient who developed lymphoma actually sued the Monsanto company for like $300 million because he got lymphoma from exposure to Roundup, and he won, which gives you some idea. He won. And so you could assume that Monsanto was not pleased about that. But there was a major legal battle in which a fair amount of scientific data was presented. And since then, there are around 5,000 cases being litigated in follow-up to that, to give you some idea of the scope of the problem. There are many, many patients with lymphoma who have been exposed to Roundup. So that's one example. Another series of examples relates to the 9/11 event and the follow-up to 9/11, some of the chemicals. The one chemical that they identified there is a chemical called butadiene, 1,3-butadiene, where there's some linkage to myeloma. So what are called volatile organic chemicals, a variety of these things, which include pesticides and sprays, I think that could definitely be of concern related to myeloma. And we just don't have strong data on each one of them, but I would say for sure that there should be serious caution for those kinds of chemicals.
All right.
Yeah.
Doctors, thank you very much. Big round
All
of
right.
applause.
So, thank you.